Good afternoon, ladies and gentlemen. Good afternoon to Oxford, good evening to Guangzhou, and good morning to Baltimore. Thank you for being here with us today. We are very pleased to be able to welcome our speakers, as well as those of you in the audience. In the editorial of the New England Journal of Medicine in the August 12th issue of this year, the authors from the COVID Collaborative in Washington, D.C., and from Boston Harvard Medical School name long COVID our, quote, next public health disaster in the making, with 30% affected after COVID disease and over 15 million cases to be expected in the US alone. This may be an article focusing on the US, but we cannot deny that we are challenged on a global level. Today, we are coming together in our first virtual International Long COVID Symposium. We will focus on different perspectives on long COVID, both from a professional as well as an international point of view. We hope to get a better understanding of long COVID as a syndrome, its symptoms, and, as healthcare professionals, different approaches to its treatment. Before we get started, I would like to express my sincere appreciation to Median, Dr. Schmidt, and Dr. Golania, who made this event possible. My name is Dorothee Altmann. I'm currently affiliated with the University of Witten-Herdecke in the western part of Germany. I studied clinical psychology as well as ethics and organizations and work on the intersection of healthcare, communication, and organizations. An interdisciplinary approach is something that will get increasingly more important as technology and global events such as COVID bridge the gap between countries and communities with increasing speed. In today's format, we invite you, the audience, to write us your questions during all times in the chat. We will read them and work them into our question sections as well as our panel discussion. If you have more detailed and specific questions, we like to ask you to contact us afterwards. We will post a follow-up on this page with a Q&A where you can find the answers to your questions in case we weren't able to work them into one of our discussions. With that being said, I give the word to my colleague, Chris Altmann.
Dear colleagues, co-workers, friends, guests, ladies and gentlemen, also from my side, a very warm welcome to this unique and fascinating meeting. My name is Chris Altmann. I am one of the cardiologists with Median. My workplace is a rehabilitation clinic in a small town near the city of Dresden, which is located in the eastern part of Germany. Our clinic takes care of COVID and long COVID patients in relevant numbers since the beginning of 2021. I'm proud to be part of this community, determined to improve the understanding and the care of patients affected by the long COVID syndrome. Maybe for the first time, it has been possible to unite researchers from all over the globe to connect their work and their visions for the future of better and sufficient recognition and treatment for those affected by long COVID. I am convinced that this meeting will open and enhance international expert collaboration to create more awareness of a syndrome that still is negated or neglected even by healthcare professionals, at least where I live. I wish all of us an inspiring and meaningful meeting and hopefully closer contacts and better cooperation beyond regional boundaries in the future. After these remarks, I would like to introduce to you the CEO of the Median Group, Dr. André Schmidt from Berlin. Dr. Schmidt was one of the first leaders in healthcare in Germany who very early, as in March 2020, saw the need to design and implement rehabilitation concepts for COVID patients and after that for long COVID patients. Due to his commitment, Median started early with COVID rehabilitation programs and is now by far the leading player on the German and maybe on the European market with over 2,500 patients having been treated by now. Dr. Schmidt, we are glad to have you here, and we are looking forward to your opening speech for the meeting. Dr. Schmidt, please.
Thank you, Mrs. Altmann and Dr. Altmann, for your kind introduction. Ladies and gentlemen, dear speakers, I also would like to take the opportunity to welcome you to our International Symposium on Long Covid. I'm amazed and proud that we as a private rehab operator had been able to organize this top-class symposium. This means we have something to contribute to one of the biggest challenges to the people on earth, and so has the whole rehabilitation system in Germany. End of February 2020, no one in Germany, like in any other part of the world, really knew how the following months would look like and when a relieving vaccination would be available. What, and that is what I want to stress here, really would have been worth the Nobel Prize for Medicine this year. We all were under the impression of the devastating pictures from China and Italy, and were thinking, like every other country, how we would approach this deadly virus. In addition to that, I had at that time the responsibility for around 15,000 employees and their families, when politicians in Germany were discussing not only to forbid any elective surgery, which makes up about 1/3 of my occupancy, but also to close rehab clinics like hotels to avoid infections, as if he had no clue on hygiene. Two important reasons not to wait and see, but to do something. I wrote to every health minister in Germany and tried to engage with health politicians in Berlin to make clear, rehabilitation is not part of the problem, it is part of the solution. Not only were we able to help emptying an acute hospitals faster or to participate in the ventilation with our neurological clinics, we also needed to continue, or better, to improve our care in the areas of addiction or mental health, where patients are even more vulnerable in such a crisis. But even more, what should we do with the vast number of patients we expected at that point of time who needed hospital treatments but no ventilation? And what about those patients who survive after 5 weeks of ventilation independent of age? Living rehabilitation now for 20 years, the idea was natural. They would need a good post-acute rehab that combined mental as well as somatic therapies. So beginning of March last year, I contacted Dr. Altmann, our speaker of the medical board cardiology for the internal medicine, and Dr. Schröter from the orthopedics, because I assumed they would have nothing to do in the normal field anymore for a very long time, and asked them to develop this set of treatment pathways for median. They developed our interdisciplinary approaches together with their colleagues, also from the other, especially the psychotherapeutic indications, within 14 days. From the pension funds, we got approval in around another 14 days, and thus our first patient was admitted to us on April 14th, 2020. Based on our standardized IT system we developed in the past 10 years, and even more importantly, on a culture where the medical directors exchange naturally, we distributed the approaches to all of our hospitals and were able to measure outcomes from the very first patients, also in all of our hospitals, identically. So we all fought for keeping our rehab hospitals open and for giving them a role in the crisis. And good luck, the politicians understood, and thus we were able to help, as of today, more than 3,500 COVID patients ever since. Given our early interventions in post-acute COVID rehab, the first ideas on the existing of never hospitalized long COVID patients arose in Heiligendamm in one of our hospitals in July or August last year already. Long COVID, as you heard this already, will probably hit more people severely than we have seen patients who needed ventilation in the corona crisis. We have no idea on long-term chronic effects which will develop the next 20 years and which we may reduce with the right treatments today. And this especially includes, and that is something personal for me, having 3 children at the age of 12 and 2 times 10, who we ignore in vaccination programs because we decide in Germany, for me as a biochemist, completely not understandable, only based on acute effects. Medically, I would say, and here I'm pretty optimistic, we managed the acute phase of COVID more or less. But now the long-term rehabilitative work only just started. And here we need much more knowledge. Median is happy to share its data we collected over the past 18 months and to continue to participate in the research for the well-being of our patients. I'm very much looking forward to this symposium, and thank you very much for your attention.
Thank you very much, Dr. Schmidt, as well as the initiative you have shown to meet the needs of long COVID patients with Median. Now it is a great pleasure for me to introduce our next speaker, Professor Hangming Dong from Nanfang Hospital, Southern Medical University in Guangzhou. There, he is the Vice Director of the Department of Respiratory and Critical Care Medicine. We are especially grateful for Professor Dong's contribution today. Due to the international meeting we have, our speakers are in different time zones, and Professor Dong is joining us at almost 10:30 p.m. from China. Thank you very much. Even before COVID-19, Professor Dong established international cooperation and exchange. He obtained his postdoc from the University in Southern California and came to Germany in 2016, where he was part of an expert group dedicated to broaden the mutual understanding of pulmonology, its processes and context in both countries. Since 2020, Professor Dong has been involved in the prevention and control of COVID-19, the diagnosis and treatment of patients, and participated in the consultation of critically ill COVID-19 patients. His research focused on the factors associated with the duration of hospital stay and complications in patients with COVID-19. He will now give us a Chinese perspective on acute COVID prevention as a strategy against long COVID. Thank you very much, Professor Dong.
Okay. So let me share my slides. Okay, so is that clear?
Yes, that's clear.
Okay, thank you. Thank you for the invitation. And I think we talk about long COVID, and actually the title is from the perspective of a Chinese physician. Actually, it's me. So as we know, the COVID-19 actually outbreak in Wuhan. So in China, actually, we suffered a very tough time last year. But honestly, nowadays, I mean, everything goes back to normal, even in doctor, in clinical, in the commercial company. So everything, I think nowadays is go back to the normal. So the new problem as this issue is long COVID. So what is long COVID? Actually, at the beginning, we confused why for some patient after the nucleic acid is become the negative, but they still have symptoms. So let's see. That means the post-COVID conditions is a wide range of new, returning, or ongoing health problems people can experience over 4 weeks after first being infected with COVID-19. So this is number one. Number two, let's see, even people who did not have COVID-19 symptoms in the days or weeks after they were infected can have post-COVID conditions. So that is very interesting. Even I have several patients, there is no symptoms, but only the nucleic acid is positive. But after 2 or 3 weeks later, the nucleic acid is become negative. But some patients, they complain they have short of breath and their mood is changed. So that is weird. And all these post-COVID conditions may also be called the long COVID. So, I mean, very interesting is why? What's going on? What's the problem? So there are a lot of the hypotheses. I think search the paper. So the main hypothesis is persistent chronic inflammatory process. I think that is true because when I face very acute, very severe, the COVID-19 patients, it's very important to cure their inflammatory, like the interleukin-6. So as the paper shows, the high levels of CD27, like IgG B cells, is associated with autoimmune disease, such as multiple sclerosis and CT8 positive C cells, like Th1, Th17 cytokines, and the high levels of endothelial activation markers and the pro-inflammatory mediator, such as TGF, VEGF, even B cells impaired response given by like interleukin-6, interleukin-10, that is the imbalance. So this is the issue. Once we understand the inflammatory exist in our circulation, so they can, I mean, affect a lot of the organs and can induce the symptoms. So let's see the types of the long COVID. I mean, a lot of the symptoms, new or ongoing symptoms like the difficulty breath, short of breath, tiredness, and some patients, they complain they have cough, dry cough, chest pain, headache, sleep problem, even mood change. But for me, actually, in my experience, several patients, they complain is short of breath. And we test the CT scan, we do the lung function test, everything is normal. So this is, I mean, it's weird. Why will affect, can induce these kind of symptoms? And some patients, they complain they cannot sleep. And some patients, they will say, once after they do sport, like play basketball, football, previously, for them, it's okay, half an hour, 1 hour. But nowadays, they will say, since it's tired after the sports. So this is my experience of the symptoms. And actually, I mean, multiple organs effects of COVID-19. Some people, they had very severe illness with COVID-19 experience, multiple organs effects or autoimmune conditions over a long time with the symptoms and the lasting weeks or months after COVID-19 illness. Actually, I will mention a paper published in Lancet, I think at the beginning of this year in China, is they found for the very, I mean, critical or severe patients after they, I mean, recover and even the nucleic acid is negative, but they have a lot of the symptoms. I think this is long COVID and it's relevant with their at the beginning symptoms and even the inflammation. So it's also including like heart, lung, kidney, skin, brain, autoimmune systems. And some people, especially in children, there's multiple system inflammatory syndrome. So we should be very careful. And for the very, I mean, severe weakness and exhaustion, like the post-ICU symptoms and mental health effects. This is, I mean, it's common in ICU patients, in very critical or very severe patients. So the problem is how to prevent COVID-19, the long COVID. I mean, this is actually for me, I think it's impossible. We cannot prevent long COVID because so far we even cannot prevent, cannot anti-COVID-19. There is no medicine is totally 100% works, but we still can do something. So for me, from my experience, I think the early intervention is very, very important. The early detection, early reporting, early isolation, early treatment, this is the fundamental way to prevent all symptoms of long COVID. Because at the beginning, I mentioned inflammation is very important, is a key issue relevant to the long COVID. So if at the beginning we can control the inflammation, reduce the inflammation storm, I think it's actually protects the patient's organs, and it can reduce the symptoms of the long COVID. But as I mentioned, for some patients, even they haven't symptoms, but they still can, after 1 month or 2 months, they have the long COVID, have the symptoms. I think this is very important. We need to pay attention about their cytokines, their inflammation factors. So maybe because of these kind of the issues can induce the symptoms. Even at the beginning, their nucleic acid is positive, but there's no symptoms. So what we are doing in China, I think vaccination is very, very important. So far we have 6 SARS-CoV-2 vaccines already approved by our country, and 20 SARS-CoV-2 vaccine has been licensed for clinical study in China. And to date, more than 2.1 billion doses of COVID-19 vaccines has been administered. And even what we are doing, we implement graded vaccination. According to the risk exposure and the risk infection, we divided 3, actually like the 3 group of the patient. High risk population means like the doctors, nurses work in clinical. So for this patient, priority to receive vaccination. And the suspectable population, like the elder, like the children, and the general population. So this is very important. I can have a case. I mean, you know, this year in May, in Guangdong have the outbreak of the Delta mutation strain. And our experience we found is very important at the beginning. We found the population of those who had not been vaccinated was significantly higher than those who had been vaccinated to become or develop severe cases. That suggests means the vaccination is still immune to the mutation strain. So I think the vaccination is still works, and it's very important. So for instance, I mean, on May 21st this year, in Guangzhou, the first case is 75 years old, the old woman infected by the Delta mutation strain. What we are doing, we completely controlled the epidemic in 29 days without blockade. Why? It's very important. We do the tons, the nucleic acid, the PCR test, and nearly 19 million permanent residents. Once we finish this, and we can immediately identify what is the patient, what is the contact tracing. So what we are doing, we use because nowadays everyone have the cell phones, so we can use GPS to isolate to location. So here I show you this figure. It shows in China, everyone nowadays, even in the whole these 2 years, once you go to hospital, you go to airport, you want to take the subway, the train, you have to record your health condition, normal, fever, what kind of the symptoms you have. You have cough, you have sputum, you got fever. And even, as you see the right side, the figure, we have this kind of the green code, means very safety. If the figure shows green, means you are safety, and means for other people surrounding you, they are safety. And even this kind of is also show the nucleic acid and the vaccination information. So everyone just show your cell phone, your information, your code. We can know where you're from and what about your nucleic acid in recent 1 week or 2 weeks, and even what about your vaccination information. So this is very important, I think. And for doctors, for hospital, I think it's very important is we mobilizing all the medical resources. As you see, all the departments, they should establish the cooperation relationship with immediate effort, and we make every effort to save life. So as I know, China was the first country to perform lung transplantation in patients with irreversible pulmonary fibrosis caused by COVID-19. So as a pulmonary doctor, we know fibrosis is very common in very severe patient or the illness, the patient after once they recover and you see the CT scans, more or less, you will see a little bit fibrosis. And even we have a lot of scientific and technology research. And I think that for patients, once they infected by the COVID-19, is very important is we need to care their mood and even cost. So in China, whatever you have the symptoms, your illness is very serious, and or you have no symptoms. Once you infected by COVID-19, that means the nucleic acid is positive. Immediately you will go to the designated hospital and everything is free. So you don't care the cost. And even at the same time, we have the psychological doctors. We care their mood and we care what the patients think. So what we did, once the suspected or confirmed case, you should be isolated and treat in the designated hospital with effective isolation and protection conditions. And for the suspect cases, they should be isolated and treated in the single rooms. But once they confirm the case, can be treated in the same ward with multiple patients. And for the critical case, immediately go to the ICU as soon as possible. Why? Even the patient, there's no symptoms, they have to in hospital. I think it's very important. We can monitor, we can observe the patient's situation, even the blood routine, the renal, the liver, the cytokine detection, like the interleukin-6. These factors we are very clear because for some patients, especially the acute exacerbation patient, the interleukin-6 is very high. So like the cytokine interleukin-6 is recommended to monitor, to observe. And for instance, like the oxygen therapy, because the patients, they got fever, they got hypoxia. So in hospital, we can monitor everything and we can observe their situation. We can give them the oxygen to protect them, like the brain, like the heart, like the lung. So I think this kind of the ways can reduce long COVID and can protect the patients, the inflammatory, and can reduce the inflammatory storm. So I just talk about like the antibiotics. So we should be very careful, avoid blind and improperly use of antibiotics. We still need have the looking for the evidence if the patient's white cells and like the CRP is higher, and even in the imaging infected like the pneumonia, we will use antibiotics. Antiviral therapy, as I mentioned, so far there is no one medicine it works for the COVID-19. But our experience for some antiviral medicine, if you combination together, it for some patients, especially the very, severe patients, it works. And immunotherapy, as I mentioned, is relevant to the inflammation, is relevant to the immune system. So what about use immunotherapy? I think the other trial, like the use antibody, like use immunoglobulin for the COVID-19 patients. It more or less, it works, but it's not necessary. But for the glucosteroids, I will emphasize, in my opinion, short-time use, especially at the beginning, for some patients, I mean, for the blood test you found, like the white cells, like the interleukin-6 is higher, you can use glucosteroids. It works and it can help patient to immediately control the inflammation. So I think this immunotherapy, we should be careful. And for the others, like the respiratory therapy, we use oxygen, even ECMO. And for the traditional Chinese medicine, it still needs a combination with other antiviral therapy. And for some patients, it works. And I think this very important for the long COVID is rehabilitation. And even we looking for the guidelines and for the research, only 0.4% of COVID-19 patients, they said they had participated in the professional rehabilitation program. So my suggestion is we need a long time review and follow up COVID-19 patients. I mean, like 3 months, half months, 1 year, even 2 years, for a long time to see what about their lung rehabilitation, their cardiac rehabilitation, and even physical therapy. So I think for the, I mean, Dr. Schuler can make, I mean, more contribution for the rehabilitation for lung, for heart. So actually, there is like the first added is the guidelines and show how to do the respiratory rehabilitation. So like the airway cleaning, like the breath control training. So I will mention, you know, in Guangzhou, Professor Zhong Nanshan's team, they launched a respiratory rehabilitation guidelines for the COVID-19 patient. You see, once the patient, I mean, lie or sit in the bed, they can do a lot of the physical exercise and to training their respiration. So for the very, I mean, severe, very critical patients, we should be very careful. For instance, like the dry cough and the respiratory rehabilitation is not recommended. So I just show you the guidelines because you can search online. And even we need to be very careful with the other organs like the liver, like the kidney function. Here, I also will emphasize the PCCM, pulmonary critical care medicine. I think in our experience for this, I mean, big trouble, we found we training the PCCM doctors, whatever, for the isolation, for the critical symptoms, for the, like use the ECMO, like use the follow-up the COVID-19 the patients. A lot of the issues we need very professional doctors and this kind of the team or group. So through this kind of the like COVID-19 and in China, even in our hospital, we are training our group, our team. And I think the PCCM is very important. Whatever the patient have the symptoms or not, and very severe symptoms, we should be very, I mean, cooperation. And even, I think it's very important, we need a set cooperation with the other departments, like the heart, like the, even like the psychological doctors. We need to have this kind of a team and to help patient. And even nowadays, honestly, it's very less case in China because a lot of the patients infected patients is imported. It's not in China. So last one, I will say that the COVID-19 is a very common threat worldwide. That means we need to look how very close international cooperation and we can fight this kind of the new virus. Okay, thank you.
Thank you very much, Professor Dong. Thank you for that fascinating insight into the Chinese perspective. We have some short questions from the chat I'd like to ask you. what is the degree of long COVID problems in China right now?
Actually, as I mentioned, last year, we suffer, it's a very tough time. But nowadays, everything, for me, it just go back to the very normal work and whatever in hospital. Because for the discovered infected patients, they will send to the specific hospital. And there, they can take observation, can take accept the treatment. So for the other hospital, they just focus their previous work. So everything is just go back to the normal.
Thank you very much. The next question would be, which symptoms are most common in China?
For my experience, I think like the short of breath, tired, especially after sport. And for some patients, they will complain like the sleep is not good. So most of the patient I met is like this kind of symptoms.
Thank you very much.
Yeah, it's still relevant to the lung.
Yeah, okay, so a focus on the lung symptoms. Interesting. What is the effect of the vaccination on long COVID in China?
You mean the vaccination, right?
Yeah, the effect of the vaccination.
I think through our experience, I think whatever, the virus is already mutation, like the Delta. I mean, maybe in the future still have the mutation. But nowadays, I see the vaccination is still works, more or less. They cannot totally fight the virus, but they can protect the patient develop to the very serious or very critical issue. So I think for the vaccine, it still works and it can help the patients. And also, if everyone takes the vaccine, we are safe. It's not only us, surrounding the people. Everything is safety.
Thank you very much.
Professor Don, you showed us impressive data how consequent in your country corona crises are being dealt with. And do you think that by this structure, you could avoid some or many cases of long COVID symptoms? Maybe in China, there are not as many long COVID patients because you are more consequent in dealing with acute COVID disease. How would you think about that?
Yeah, very good question. Actually, for me, I think it's a lot of the issues. For some patients, maybe they, after the nucleic acid is negative and even they recover. So they will not go back to the hospital. And for some issues, I think it's, at the beginning, if they can be treat or accept the treatment or the control the inflammation, it's more or less will reduce the symptoms like the long COVID. So I think that at the beginning, if we can, the patient can accept whatever the treatment or the monitor observe can reduce these kind of the issues.
Thank you very much. You have a well-developed infrastructure for dealing with COVID problems in your country. And as far as I know, you built COVID clinics, hospitals. I don't know if they're still operating. So what is, in your opinion, will be the development of the infrastructure for treating COVID in your country in the next 12 months? Will the hospitals be changed into rehabilitation facilities? Will there be special treatment topics, or will it all slow down and go back to normal completely? What do you think, Professor Dong?
For instance, in Guangzhou, nowadays we have a very special, like it's not like the hospital, but it's can call the hospital. This kind of the specific hospital is once the patient, whatever they infected by the COVID-19 or just contact the patients, everyone, they will go into this hospital and they can be observed And once they have symptoms, they can treatment. And for the other hospital, they just go back to their normal work. So I think this is very important because since this COVID-19, we need to fight with it a long time. We don't know, maybe 2 years or 3 years, but I think we still need to go back to the normal. So nowadays in China, everything is just go back to the normal, whatever in clinical or in the people's life. But it's very important, we cannot spread the patient, especially for some, no symptoms patients. That is to be very dangerous. So that's why whatever in airplane, in the subway, in bus station, everyone, if they want to take bus, they need to show their nucleic acid result. So for me, in our hospital, 1 week, we need to test 2 or 3 times nucleic acid. So make sure everyone, your nucleic acid is negative. I think that is works.
Thank you very much also for your engagement. Do we have some more questions from the audience? Maybe one question would be space for.
Yes. How does the cooperation in China look like right now between pulmonary experts and psychological experts in order to deal with the psychological symptoms of long COVID?
Okay, yeah, very, very good question. Because, for some patients, even the imaging, even the blood test, everything is okay, it's normal, but they still complain, short of breath, complain that the sleep has problem. So we will, with the psychological doctors to see what is the problem. Is the patient have these kind of simple symptoms because of COVID-19 infection or other issues? So we will identify. And actually some patients is not because of this virus. I have one case, one patient have the long time, around like 3 months is complaining, every night cannot sleep. We did everything, like the MRI for the brain, like the CT for the lung and the blood test, everything is normal. So I talk with the psychological doctors, why have this kind of problem? So the psychological doctors ask these patients, what about his family? What about his income? Or finally we found, because of these guys infected by the virus, the COVID-19, he lost his job. But he cannot say, because he's man, he cannot say, I cannot afford the families, the financial. So every night he just, because of this problem, cannot sleep. So finally we think this is not long COVID. It's because of other issues. So I think it still need a cooperation with the psychological doctors. Once we match this kind of the patient have the mood or the other issues, we need to identify. It's not everything is because of the long COVID. Yeah.
Thank you very much for this interesting and broad perspective on Chinese long COVID, and for this last answer that highlights the important issue of social impairments that people still experience due to COVID. Thank you very much.
Okay, thank you.
I give the word now to you, Chris Altman.
Okay, thank you for your talk, Professor Dong, and for the discussion. Following the schedule, it is now my pleasure to introduce to you 2 pioneers in digital health solutions from Oxford, UK, Dr. Peter Wright and Dr. Stan Windsor. Both are experts in the treatment of COVID-19 patients, and both have a scientific and clinical interest in sports medicine. They are working at the Brookes University in Oxford, UK, and they have founded a startup company and have developed an app to promote COVID rehabilitation via mobile devices. Dr. Wright and Dr. Windsor, welcome to this meeting. We are looking forward to your presentation.
Thank you very much, Dr. Altman, for the introduction and giving us the opportunity to talk about something slightly left field, about technology. Stan and I will try to squeeze a bit of a brief on technology opportunities and options to treat long COVID from a rehabilitation point of view. The view here, the picture that's from our campus in Oxford, beautiful. And unfortunately, I haven't been there for a long time now because of COVID restrictions. And this brings us to the introduction here. So home isolation and restrictions during COVID challenge and have challenged an active and healthy lifestyle. And on top of that, rehabilitation structures do vary a lot. In many countries, they are overwhelmed or even non-existent for long-term interventions. And this is, for instance, the case in the UK. If we look pre-COVID at pulmonary rehabilitation, and only 87% of all respiratory patients had access to pulmonary rehabilitation programs. 87% didn't have access, which leaves 13% who could potentially participate in pulmonary rehabilitation, and that was not always taken up by 30% for various reasons. And the program itself across the UK generally is about 12 sessions long over a 3-month period, so it's obviously not long term. Therefore, in the UK, we do focus a lot on digital and technological solutions and to give these patients access. So a bit of a need there, which possibly gave us a bit of a head start. So what we'll cover today is we'll look at the holistic approach in digital use in terms of rehabilitation of long COVID. And by holistic, obviously, we mean not just the exercise interventions, but a bit more. And it's not just one technology. Usually it's a whole suite of technologies. There are certain considerations for long COVID rehabilitation, of course, especially when it comes to digital provisions. And there are pros and cons. There are benefits, but there are also risks attached. And therefore, we need to have a very close look at comorbidities, etc. Then, obviously, there are certain first choices of exercise that we might want to introduce, and we'll talk a bit more about strength exercise in this context. And then in more detail, Stan will talk about a long COVID rehab app. So moving on, the digital technology and holistic rehabilitation process for long COVID. First of all, the choice of exercise intervention. And there are some lessons learned from other conditions and their rehabilitation, and there's a bit of overlap in symptoms. As long COVID is a fairly new challenge, of course. Patient education always needs to play a role. Then how to use technologies in a safe way in a COVID rehab setting. But we don't just mean, for instance, the use at home of an app, but it could also be in a hospital, etc. Patient tracking and feedback and therefore engagement is a big one, especially when it comes to safety considerations, motivation, and effectiveness of training. And the last point is also other healthcare professionals need to be involved when it comes to the education and information dissemination to the patients. So you can't and should not see one technology in isolation, but it should be an umbrella with a holistic approach to this problem. Okay, if we move on, these are the two examples. So today, there's so many, when we talk about technology, I mean, we have a whole teaching module, emerging technology in health in my department. So we're just squeezing it into 22 minutes today. And we focus on two things. One is mobile phone apps and the hardware behind it. And what we see here is an iPhone with a new generation of camera system, a 3D capability. And that enables us, for instance, to use augmented reality. And augmented reality probably in the next 8 years or so will be a huge leap in terms of development. We've had a project when looking into cancer rehabilitation with augmented reality. You can create avatars, you can give live feedback for patients. So all of a sudden, a simple mobile phone becomes something that before was almost impossible to think of. Now, we're not talking about virtual reality here. That's something different and a completely different kettle of fish. but we leave that out for today. And then on the left side, what you see is something called pixformance. And that actually has been trialed and tested in a COVID environment. So during the peak of the pandemic, this device was used in a few hospitals. One of the most renowned one is the Charité in Berlin. And it basically, whenever you either are short-staffed or especially when face-to-face exercise or rehabilitation interventions need to be reduced, that was a very useful option, easy to disinfect, and it also uses an AI. So if we move on to the next slide, I'll just briefly explain the features. And we have the same device in our lab in Oxford, and we also incorporate that in a EU-funded recent or current study in oncology rehabilitation. So this device is about 1.55 meters tall, looks a bit like a mirror. You can see yourself and you can see an avatar, and it gives you live feedback. So there are over 100 exercises programmed. There are in-unit sensors that enable real-time movement analysis and feedback. So it tells you you're moving too fast, you're not lifting your left arm high enough, or you're not bending far enough, etc. And that is done by 3D sensing technology using 26 anatomical reference points. And there are other devices on the market that use less, which are not as good and couldn't be classed necessarily as a medical device. But this actually does the job and has, as I said, been tried and tested under COVID conditions in hospitals. There is an artificial intelligence incorporated in it. So you can either just have a baseline exercise program and then leave it to the artificial intelligence to do a safe progression. For the clinical use, obviously, there still needs to be some development done for certain conditions, which we are currently doing, for instance, for cancer. Or a physiotherapist or other exercise professional can monitor and program this device. It also enables you to do data analysis to a scientific level, and of course is easy to clean, to disinfect, etc. It comes on wheels, so you can move it around. You can just have it in a patient room, or even issue it to a home of a patient if required. But it can also, especially in times of stretched human resources, have 10 of these things and do group exercises just supervised by one physio exercise professional / therapist. So this is something that we find as a digital solution very helpful, especially in times of overstretched resources. Now, if we move on, I'm handing over to Stan here. Stan, over to you.
So when we talk about using digital and especially mobile technologies, people often ask what the benefits are, and the literature shows that one of the main benefits is the adherence that patients have to the rehabilitation programs that are provided through mobile technologies. The Netflix generation, as we call it within digital technology, the on-demand generation. So the ability to allow people from different socioeconomic backgrounds the same access. So whether they are remote, so can't get to the hospital, whether they might have a job that means that they can't come to daytime rehabilitation groups. On demand, in your house, at home exercise through mobile technologies is a really good way of improving patients' quality of life by giving them the access to rehabilitation, but also patient adherence to exercise that might not have been there before. Even before COVID, the National Health Service in the UK highlighted that they needed a more digitally enabled healthcare system and included it within their long-term plan. But on top of this, they also included that they needed a more personalised and bespoke healthcare system. Through focus groups that we've run when setting up new mobile technologies, patients like to feel in control of their own healthcare. So feeling that there's something has been adapted for them and are prescribed for them using augmented reality, AI, machine learning is a really good way of increasing their adherence to this exercise. COVID-19 has accelerated the adoption of exercise and mobile technologies. And so really we're on this wave of acceleration. The literature suggests that about five years of acceleration to the uptake of digital devices. So when I talk about mobile technology and making it bespoke, what we're really talking about is understanding that, especially within the COVID-19 situation, that the aging population are a population of comorbidities. So the people that were most at risk of catching COVID-19 were older populations. So might have osteoporosis, diabetes, obesity, rheumatoid arthritis, these sort of conditions, cancers, immunocompromised with cancer, etc. So treating the condition of COVID-19, but being sympathetic to the other conditions that they might have, also greatly increases patient adherence to the exercise. Then allowing us to build a much more personalized plan. We use validated tests and scales that are already out there, dyspnea scales, CRQ, chronic respiratory questionnaires, and then basic fitness testing, as well as rate of perceived exertion pre and post exercise. Allows us to build an algorithm that is accurate, progressive, and prescriptive to the patient.
Yeah, and despite this one technology for exercise and rehabilitation, of course, we now need to look at the bigger picture when it comes to other healthcare professions, etc., as part of the rehabilitation process. And one of the best things, I think, in terms of exercise as medicine and education that internationally is around, but definitely in the UK, is moving medicine. So it's a free tool. And please do visit the website, movingmedicine.ac.uk. They have bespoke educational tools and kits for active hospitals, and all based on motivational interviewing. So this is an example for COPD, for instance. You have adult population and young population, children, etc., adolescents, and then the specific most prevalent conditions. And you have the options, almost like an idiot's guide, really. The 1-minute conversation, the 5-minute conversation, and the more minute conversation, as I said, all based on behavioral interviewing and backed up by promotional videos, by posters, by evidence, literature review, so that, you know, even a nurse who might not be an expert in exercise medicine can become a bit of an expert in very little time. And it's ready to use there straight away with the patient. And that then obviously promotes patient education, adherence to exercise, etc. There's obviously also a toolkit for long COVID. And what I would like you to show a bit of British humor involved in this as well. Just part of this video, the COVID recovery video, which is only one kind of piece of in the jigsaw of the long COVID toolkit. So if I may ask our colleague to play that video, please, just for a minute.
Good day to you all. You may be recovering from a coronavirus illness. If you are, do remember that nature knows best, and follow these handy tips from healthcare professionals, brought to you by Professor Elemental.
Recovering from COVID can be tough and confusing. Let's start you with a few basic movements. Take a few deep breaths and soon you'll find that you'll feel improvement. You need to be kind to yourself. My gosh, you've been through a lot. Reduce the odds of feeling like you lose the plot. If you feel off, your sleep patterns are a mess, some routine will help you. Plan in some rest. Now work gradually till you're at your best. You've made it this far, here's a hand, I'm impressed. Now stop, rest, sit down if you're hanging on. This is not a sprint, this is more of a marathon. Be not afraid, be kind to yourself. You need to rest up, redefine your health. Take your time, take it slow, keep moving. It won't be easy, but you'll see some improvement. You're not on your own, even if you're alone. Keep an ear out while you're stuck at home. Take your time, take it slow, keep moving.
Stop it here for time reasons. Thank you. Right, so this is only one part of the toolkit. Please do visit this, and it basically is part of the whole suite of digital options in treating long COVID. If we can move on to the next slide, please, Stan. Thank you. So we're now looking into considerations for long COVID rehabilitation. And Stan has already mentioned that before, that disease and age recognized risk factors need to be considered when it comes to long COVID rehabilitation, especially in a virtual or digital environment, because there are risks obviously attached to it. If we talk about obesity, diabetes, cardiac disease, or pre-existing respiratory diseases. And without a face-to-face supervision, that is obviously a challenge. But there are certain technology solutions to do that, like the ones with questionnaires, with scales, breathing scales, etc., involved. then the second point is really important. The low physical functioning in COVID survivors and long COVID patients, because obviously inactivity, bed rest, etc., might be appropriate at the time, but obviously always has a negative effect when it comes to muscle wasting, which then has a knock-on effect to activities of daily living and a bit of a vicious cycle. And then, of course, what we've learned from other conditions with similar symptoms, not the same pathogenesis, of course not, but it's a long COVID rehabilitation is a new challenge. And I believe that Median is leading in Germany in that respect. We have looked into other conditions like chronic heart failure and COPD, even oncology rehab, to learn about what works with these similar symptoms. So if we move on to the next slide, please. So this is based obviously on what we know about rehabilitation of other conditions, in this case COPD and chronic heart failure. So subjective symptoms are similar in terms of breathlessness, dyspnea, and fatigue, which significantly increase during physical activity. So that's a common denominator. Then similar vicious cycle of inactivity caused by disease symptoms and leading to deconditioning, which then impairs the recovery process and can lead to long-term problems, even psychological problems, isolation, etc. Then inflammation processes, increased in pro-inflammatory cytokines, that can lead to chronic inflammation over a longer duration. Then obviously as a consequence of that, usually find higher cortisol levels and a catabolic response, which again promotes muscle wasting and sarcopenia. This is something that I'm not aware of, that there's evidence in long COVID patients, male patients, but we know that from CHF and male COPD patients that these patients suffer longer term from low testosterone IGF levels, which again promote muscle atrophy. And last but not least, chronic hypoxia, increased acidosis in these COPD patients, CHF patients, negative energy balance. So we basically derive from this what has worked in those populations in terms of rehabilitation and what could be used, for instance, for digital rehab solutions. And this is basically the rationale now. And you've heard me talking about muscle wasting, muscle atrophy, sarcopenia, etc., which obviously is one of the issues as well, despite all the respiratory problems. And what we know also from oncology rehab, chronic fatigue symptoms are less likely to be triggered by a moderate strength exercise than by continuous aerobic exercise. And the one thing that we need to avoid is to give the first exposure, give the patient a negative experience with the first exposure to exercise or rehabilitation. Dyspnea is also less likely to be triggered because of the intermittent nature of strength exercises. So it's definitely a good starting point. It doesn't mean it's the answer to everything, but it's a good starting point. Sedentary lifestyle due to long COVID symptoms also triggers significant muscle atrophy and thereby limits the activities of daily living. And just to give you an idea, for people who are not necessarily involved in the exercise medicine area, 10 days of bed rest can cause 14% of muscle mass loss, which is huge. And that obviously has a knock-on effect on all other organ systems as well. Chronic inflammatory processes promote the catabolic state, and strength exercises are basically an antidote to that. And to kill two birds with one stone, as we say, the good thing is also strength exercises can develop or support breathing muscle groups, as well as are very similar in terms of breathing technique to breathing exercises. So you have a long breathing out, exhaling phase, you purse your lips, etc. So it's all very mindful, and that's basically similar to breathing exercises. Right, the next slide.
So looking at the funding for the application that we built, it was originally for long COVID, and the government funding that we got was to build an application for long COVID. But one of the downfalls within innovation, especially within the medical area at the minute, is how the industry keeps up and medical innovation keeps up with the public rules. So when we built our application, it was declined from the App Store. It couldn't be put on the App Store because it had long COVID in the name. And so we had to be a government authorized institution to put it on the App Store. So unfortunately, we had to pivot. So you will see references to COPD within the slides now, as that's the sort of condition that we've placed long COVID rehabilitation under within the UK. So pre-COVID, the access to pulmonary rehabilitation was a major economic and health crisis. As Peter's already referred to, only 13% of people were able to access pulmonary rehabilitation. This number has obviously been extrapolated because of the amount of long COVID patients going into the same pulmonary rehabilitation units. And then some figures here below, but I think the one to recognise from an international symposium is globally over 250 million cases of human death from COPD or respiratory disease pre-COVID. The World Health Organization predicts that respiratory disease would be the third biggest killer before 2030 in the world. So there's a real need to accelerate some form of rehabilitation that doesn't have a drain on human resource. So how do we do this? How do we prescribe people remotely from home? So as we've said before, the main issue is around holistic screening. So finding out as much information about the person as we possibly can. Basic information like height and weight gives us obesity levels. From that, we can exclude exercise and prescription that might have an adverse effect on them. So taking out any exercises with high bandwidth or jumping exercises. So the same could be said if someone says that they have osteoporosis or rheumatoid arthritis, taking out exercises that aren't applicable to them. Then asking them about things around their daily living. So as you would with any COPD patient, how hard do they find it to climb the stairs, take out the shopping, get out the bath, etc., reach above your head? These exercises of daily living give us an insight into how they might react to exercise. This allows us a greater option to their prescription level and greater insight into their prescription level. The other key factor that we put in is daily assessments. So anecdotally, when a patient comes in to see a nurse or a doctor and they ask how you are today, you're going to hear about how they were on that day in that moment. Very rarely will they be able to retrospectively consider their last 3 days. So by having a daily assessment tool that checks in on their oxygen saturation levels, fatigue levels, peak flow levels, on a 3-day rolling average, this allows us to build up a much better, more holistic impression of the patient. This then feeds into our training levels and prescription, so allows us to progress or regress on a 3-day rolling average rather than a 1-day snapshot. It also increases the adherence to the application and the platform, allowing people to interact with it on more than just the 3 or 4 days that we recommend that they train on the application. Fail-safes within medical devices. So handheld health is a medically registered device within the UK by the MRHA. Fail-safes are required for safety, and it also allows us to collect additional data. So if someone reaches an at-risk fatigue level, we recommend they don't train. An at-risk breathlessness level, we recommend they don't train. And these fail-safes run through the application itself as well indeed. So if someone says that they might are struggling with an exercise or skip an exercise, we then take a snapshot of their breathlessness level. On a modified Borg scale we use, if someone signifies that they are extremely out of breath, again, we can offload them, but more than that, we can reduce the exercise prescription for the next time they use the application. So all the data then goes back into the AI and is repurposed to allow progression, but also regression of the exercise prescription level. After exercise, so post-exercise RPE scales, rate of perceived exertion, allow us to keep in a progressive target range. So we want to try and keep people working at a 5 or a 6. Again, when we're prescribing exercise simply for COVID-19, and it's very rigid that you have to have a doctor re-prescribe it or a physician re-prescribe it every time, you can't have this progression, continual progression on a day-to-day basis. So just very quickly, I'm aware we're out of time, but what are our next steps? So we have worked on the prescription levels and the exercise prescription levels, but we also recognize that we need to adapt the application for a holistic view of rehabilitation, looking at the psychosocial, so the social mobility of people, reducing social isolation of these cohorts through messaging and group event bookings, collaborative goals, etc., as well as the relaxation techniques that Peter was talking about and nutritional advice. Finally, the health economic analysis from using a digital intervention such as handheld health shows an improvement in quality adjusted life years by 1.23%, but also a cost saving of approximately 400 British pounds. That's a £322 per QALY on an ISA, which is a huge amount considering if we extrapolate that over the literature that suggests that digital rehabilitation can triple the capacity of physicians to treat conditions. Something like COVID-19, where we've had a huge influx and struggling with staffing levels, could make a huge difference. Sorry, slightly over time, but thank you very much.
Thank you so much. That was a very fascinating insight into the results and into the intelligent tool you've developed to help long COVID patients improve their health. Fascinating healthcare startups often get into problems because HMOs are slow in evaluating and even slower in certifying or even reimbursing such projects. But without that, the health effects would be limited to a few instead of being rolled out into the affected population. What are your experiences, your visions, and your hopes?
So as I said in there, we have had first-hand experience of this. We wanted to launch an application for long COVID, but the rules and regulations and uncertainty around a rapidly evolving situation meant that we couldn't release it under the umbrella of long COVID. So we absolutely understand that. Personally, I'm aware that the EU the European Union are working on rules and regulations around the medtech and medical technologies sphere with applications and digital technologies. This needs to be accelerated. What the industry is lacking is regulation, and without that umbrella regulation, no one's quite sure where applications sit. Without that, we haven't got anywhere to go with them. So actually, it is my opinion that we need to strengthen the regulations and accept applications within that regulation quicker, sooner rather than later.
Yeah, I would just add to this in terms of certifying. That's fairly straightforward, at least in the UK. And we managed to get this certified as a medical device straight away. In terms of remuneration for the services, it's a bit of patchwork in the UK because you've got the clinical commissioning groups, and now the big purse string holders are going to be the integrated care services. And there are many of those. Usually they are responsible for a few counties. Like in Oxfordshire, we've got the ICS, integrated care service, for Oxfordshire, Berkshire and Buckinghamshire, and you need to negotiate with them to basically get the buy-in and for patients to actually use it and the NHS to pay for it. So that's all possible, but you need, because it's so much patchwork, you need to do that with each ICS across the country, but it's workable. There are technologies out there or apps that are being paid for and used, and we are currently in the process of, obviously, to talk to the CCG and colleagues in Oxfordshire.
Thanks a lot. As far as we understand, your app is addressing muscular and pulmonary parameters of long COVID patients, but you still are monitoring patient-related outcome measurements within the app. It's measuring long COVID symptoms inside and outside the airway system, as far as I see. Have you seen any correlation between improvement of pulmonary long COVID symptoms and non-pulmonary long COVID symptoms?
Well, I would say that's a very good question, but it's a bit premature for us because we have just submitted we've done a usability and feasibility study, but we currently have submitted ethics applications for the clinical phase. So if you ask us again in a year, we can answer that very robustly. However, the good news is we've obviously conducted similar studies in other respiratory diseases like COPD, not yet necessarily using this technology, of course, but we do know that if there's a strong correlation between your capacity for daily activities of living or even fitness and symptoms of depression, health-related quality of life. So usually if you improve on the physical side, you improve on other aspects, psychological parameters, etc., as well. So that's what we found in studies, both for 3-month interventions and 6-month interventions, if that helps. But in a year's time.
Yeah, wonderful. Maybe a little light shed in the future, because we saw some anecdotal data that pulmonary therapy would improve even neurocognitive impairments of long COVID patients. That's a fascinating correlation, I think, if it proves, but you will be team tested. On the next symposium, I will ask you again. Right.
Yes, please. Yes, please.
Next question. At least in Germany, data safety concerns and the incomplete penetration of handheld devices are of major concern in certain subpopulations of long COVID patients. How is the situation in the UK? What is your experience and what are your suggestions to deal with it?
Well, that's a question for you, Stan.
We're actually working on another EU-funded project with a university hospital in Germany, and so have good experience with the Cloud Act that I think is your major barrier. And the Cloud Act is an act that was passed within the US that allows the FBI and the CIA to look at any data that is held on a storage device within the US. This is an EU act, and Germany takes it very seriously. Luckily, luckily or unluckily, whichever side of the fence you lie on, the UK doesn't take it as seriously. So we are allowed to host information and store information on US-based servers. So for us, it's not as big an issue as it is for Germany. It is difficult though. That stops a lot of data generation and data sharing, because a lot of the big servers, Amazon Web Server is the one that we use, for example, have powers and processes in them that aren't available on the lower or European-based servers. So there does need to be a reconsideration of that, I would say, for true innovation to thrive.
Thank you very much for your time, your presentation, and that fascinating insight into handheld health. We have now come to the end of the first part of this symposium. Please enjoy our short break. And while you're drinking the beverage of your choice, we invite you to take part in our small survey. You can see the questions on the right side of your screen when you leave the full screen option. We will work the results into our follow-up post. Have a pleasant break.
Welcome back, everybody, to the second session. We are still within our scheduled time frame, and we shouldn't overstretch the night hours of our Chinese colleagues who attend this meeting, who are awake at about 11:30 in the evening now. Thank you for still being with us. Our next speaker is Dr. Pierre Schuler. Pierre Schuler is a close colleague of mine. He's a leading cardiologist in the Median Rehabilitation Center of Flechtingen, located between Berlin and Hanover. He is a specialist in cardiology and in pneumology as well, which is a special blessing in the COVID-19 era. Together with a strong academic neurology department at his institution, Pierre Schuler has focused on the interdisciplinary aspects of the Long COVID syndrome. He is chairing our National Long COVID Working Group, the so-called Medical Board. Pierre has published on COVID topics and has established scientific cooperation between Median and the Berlin University Charité with special COVID projects. Dr. Schuler will present case reports from his institution to illustrate the spectrum of long COVID symptoms and the therapeutic concepts we have developed. We are looking forward to your talk. Pierre, please.
Thank you for the introduction, and thank you for the opportunity to present to you interesting long COVID cases from our clinic in Flechtingen. During a period of 1 year, we included over 200 long COVID and post-COVID patients in a study, and we measured out 2 groups of patients, group 1 with an acute severe course of the disease and group 2 with the acute mild course of the disease. And as a result of our study, we could see improvement in exercise performance, lung function, and different psychological parameters in both groups independently of the acute course of the disease. And we are going to present our data with a poster presentation at the British Thoracic Society meeting next month. Out of the patients we treated in the last 2.5 years, I now want to present to you 2 interesting cases. Case 1 with an acute severe course of the disease with predominantly pulmonary and physical impairments, and case 2 with an acute mild course of the disease with predominantly cognitive dysfunction and fatigue symptoms. So let's start with case number 1. Case number 1 is a 71-year-old male, former traditional basket maker with the typical risk factors for an acute severe course of the COVID-19 disease with hypertension and diabetes, with coronary heart disease, heart failure, and peripheral vascular disease. In March 2020, he was infected by the SARS-CoV-2 virus, and he developed fever for a period of 2 weeks, accompanied by fatigue symptoms and dyspnea. And when confusion occurred and the patient became disorientated, that was a turning point, then he was carried by an ambulance to the emergency department. When he arrived in the emergency department, he was in a bad condition, and his condition worsened quickly, so he required invasive mechanical ventilation. He was transferred to the intensive care unit, where a severe COVID-19 pneumonia was diagnosed, leading to acute lung failure. He was ventilated for a period of 6 weeks in intermittent prone positioning in the intensive care unit. There were some noteworthy events, a dilatational tracheostomy, extreme nose bleeding that occurred, and that was very difficult to stop. And he needed blood transfusions because of that, what is, in my opinion, quite unusual. And also cardiac arrest occurred with a necessity to perform cardiopulmonary resuscitation for over 8 minutes. So altogether, he stayed for at least 3 months in the acute hospital. As you can see from the symptoms the patient presented at admission to our rehab, he was in a very weakened state. You can see it also from the photo that he was limited in his ability to do any physical activity, including activities of daily living without support. He also suffered from other symptoms, like, for example, a wound, a decubitus ulcer on his rump degree 2 to 3. Furthermore, he suffered from psychological symptoms. He suffered from depression and from anxiety. Especially, he was anxious about getting COVID-19 again. And also he had recurring nightmares. At the admission to our clinic, we performed several assessments and several tests. In the laboratory tests, we could see an anemia. In the echocardiography, we could measure out a reduced pump function of the heart. And in the blood gas analysis, we could see very low levels of oxygen in the blood, so that he required oxygen therapy. By definition, the blood gas analysis shows a respiratory failure, so he wasn't really stable at admission to our clinic. To our surprise, the lung function test showed no major ventilatory disorder. As you can see here on the picture, in the middle of the picture, the flow volume curve is more or less okay. But after he had been ventilated for over 6 weeks in the intensive care unit, he suffered from very weak respiratory muscles, and we could measure this out in the lung function test. And furthermore, he had a remarkable gas exchange problem, leading to the low oxygen levels in the blood because of the COVID-19 pneumonia he had. The patient received a multidisciplinary rehabilitation program that was tailored to his needs and tailored to his state. And I will go through each of these points. Managing comorbidities means continuous adaptation of pharmacological treatment according to his diseases, heart failure, diabetes, and coronary heart disease. Managing comorbidities also means adjusting long-term oxygen therapy according to the blood gas analysis. Managing comorbidities in this case also means wound management. Since I mentioned it already, he had a wound, a decubitus ulcer on his rump that had to be treated by a wound manager. Since the major problem the patient suffered from was the weakness of his respiratory muscles and the shortness of breath, he performed breathing exercises to strengthen his respiratory muscles and to improve the lung function. He performed different breathing exercises for this reason. Because he also had a markedly reduced peripheral muscle strength and he suffered from peripheral muscle dysfunction, also strength training was performed and endurance training. Initially, the patient was mobilized in the patient's room. After that, individual walking training could be performed. In addition, he also trained on a motor-made movement trainer. That is, as you can see it here on the picture on the right side, like driving a bicycle with motor assistance, with the fluid oxygen tank in the wheeled walker and the pulse oximeter on the finger. So you see, even patients that are in bad condition can perform exercise training. The patient also received neuromuscular electrical stimulation because of the weakness of his muscles to strengthen his leg muscles. He also received, very important in this case, occupational therapy, functional training, and ADL training, training of the activities of the daily living to increase or improve the independency in self-care so that the patient can perform the activities of daily living adequate again. Psychosocial support included individual counseling for the symptoms of depression and for the symptoms of anxiety the patient had. Psychosocial support also included group therapy for disease processing. Furthermore, the organization of the aftercare after the rehabilitation. For example, the patient needed help with the use of his support stockings and wound care. Therefore, the social worker organized home nursing, home health care. So the social worker helped the patient to be reintegrated into family and to be reintegrated into daily life. The educational program comprised information about the disease COVID-19, the acute COVID-19 disease, and about the disease long COVID. The educational program also comprised self-management tasks, like what to do in case of health emergency, or how to manage the medication, or how to manage the other illness the patient is suffering from. Lectures also covered nutritional considerations and healthy lifestyle. In the course of the rehabilitation, the general health status of the patient improved clearly. He could perform a longer distance in the 6-minute walk test at discharge compared to admission. And also different parameters of lung function improved in the course of the rehabilitation. Also, psychological outcome parameters improved in the course of the rehabilitation. For example, the GAP-7, that is a questionnaire about anxiety, improved from 7 to 1 point. The lower, the better. And the PHQ-9, most of you know, screening test for depression, improved from 5 to 2 points. So in summary, in clinical practice, this patient with severe acute COVID-19 infection benefited from rehabilitation. So let's go over to case number 2. Case number 2 is, in my opinion, a totally different case. A 43-year-old young medical doctor in vascular surgery. She could speak 5 languages fluently. She was always athletic. Rock climbing, cycling, and skating were her hobbies. She had no major health problems. Early this year, she was infected with the SARS-CoV-2 virus. The initial symptoms were very mild, with cough, a runny nose, and fever. After temporary improvement, for some days she already went to work again, clinical worsening occurred over the course of the next weeks, but the treatment was until then still outpatient. As you can see from this slide, she suffered from a wide variety of different symptoms at admission to our rehab. In my opinion, she fulfilled the picture of a chronic fatigue syndrome with fatigue, shortness of breath, and different neurological symptoms, like, for instance, brain fog, poor concentration, and poor memory. For example, before rehab, there were some days when she did not find the way to work, or she showered several times a day because she rapidly had forgotten that she had already showered. She had pain issues, headache, pain in her right arm, pain in her right leg. She had heart issues, palpitations, chest pain, and also mental health issues. At the admission to our clinic, we performed several assessments and several tests. She presented, as I mentioned it already, with the aspect of general tiredness and being unwell. The laboratory tests showed decreased vitamin D levels, a mild anemia. In the ECG, we could see an inappropriate sinus tachycardia, possibly as a sign of autonomic dysfunction. Her hand grip strength was critically weak, as a hint for functional impairment and as a hint for functional limitation. Also, she, of course, was included in a multidisciplinary rehabilitation complex that was tailored to her bio, psycho, social, and occupational impairments. And she also received a new therapy that we try out in our clinic for some months. Supplements to reduce symptoms. In clinical practice, we gave her vitamin D because of her decreased vitamin D levels. And in clinical practice, we gave her also iron for her mild iron deficiency anemia. Since overexertion can cause exacerbation of symptoms in patients with chronic fatigue syndrome, we only gradually increased the aerobic exercise training and performed the interval training with adequate breaks and rest periods. She performed cycle and walking-based endurance training, balance and coordination training. Furthermore, she carried out breathing exercises, like for instance, resonance frequency breathing, that is a kind of biofeedback training with a short frequency and deep breathing technique. She performed also other breathing exercises like pursed lip breathing, to just name one example. Psychosocial support included individual counseling to cope with her disease, long COVID, peer group support, that means to talk to other people having long COVID, what is, in my opinion, very important, and also relaxation techniques, like, for example, progressive muscle relaxation and guided visualizations. Psychosocial support also included the organization of the aftercare. For example, she participates in our digital support group that we founded in June this year. One of her major goals was to get back to work again, to be reintegrated into work. She was highly motivated, and for this issue, she did a lot of effort herself. But also the social worker helped her to be reintegrated into her work. And now, to my knowledge, she works again in part-time as a physician on a ward, but currently not as a surgeon. The educational program comprised information about the disease COVID-19 and long COVID from different perspectives, such as from the neurology and the pulmonology. Lectures also covered coping and pacing strategies, acceptance of the disease, set achievable targets is important, and also covered nutritional consideration and the topic healthy lifestyle. Considering that there are a few small studies that have shown beneficial effects of intermittent hypoxia-hyperoxia training with regard to cognitive performance and exercise performance, we included this therapeutic option as a new therapeutic tool for patients with such symptoms. So you can see here on the picture the device the patient breathes oxygen-rich and oxygen-poor air in intervals via a mask. And on the right picture, you can see the monitor view during the therapy. You can see the oxygen saturation during the therapy. And we are planning to investigate the effect of this therapeutic approach in a study. In the course of the rehabilitation, also she improved, in my opinion, clearly with regard to her general health status, and she could perform at higher intensities, and also some lung function parameters improved in the course of the rehab. So in conclusion, in clinical practice, also this patient with a mild acute COVID-19 infection benefited from rehabilitation. So since this is now an international meeting and I presented 2 cases to you from our clinic, let's put it at the end to a more global perspective. We have over 200 million COVID-19 cases diagnosed worldwide. at least 10% develop long COVID or post-COVID-19 syndrome with a large variety of chronic health issues. An individualized, inpatient, multidisciplinary treatment approach seems to be effective. So in my opinion, this therapeutic approach should be expanded. Thank you for the attention. There will be time for questions. Thank you very much.
Thank you very much for this very interesting presentation of yours. And our first question is about a paper of yours from this year. In your paper in BMC Health Services Research, you seem to recommend that one should follow the structure of pulmonary rehabilitation when building a specific long COVID rehabilitation. How do you integrate the interdisciplinary aspects of long COVID into the pulmonary approach? And which professions should work more closely together to deal better with long COVID, and why?
Thank you for this question. Well, I think you mentioned the RACO study. The RACO study is a prospective multi-center study to investigate the effects of post-COVID rehabilitation with regard to general health status, fatigue symptoms, and also the return to work. So this is a study that is performed by the University of Lübeck by Professor Deck. And it's a very interesting study and we're waiting for the results. But back to your question, rehabilitation by definition is multidisciplinary teamwork. Different professions work together, like the physicians, the nurses, the social workers, and the result is rehabilitation. So we perform interdisciplinary teamwork for years already. It's nothing new for us. And with regard to long COVID rehabilitation, in my personal opinion, especially the neurologist, cardiologist, and the pulmonologists, as well as the psychologists and the psychotherapists, should work more closely together because of the symptoms the patients suffer from. And therefore, we implemented interdisciplinary team meeting once a week to discuss the cases, and we implemented an interdisciplinary educational program like I presented to you. And we also have the opportunity, what is in my opinion very important, for counseling, to refer to counseling.
Thank you, Dr. Schuler. In addition to your qualification in cardiology and pneumology, you were also certified in social medicine. In your experience, what aspect of long COVID has affected the lives of your patients the most? What solutions do you see to overcome this impairment on a short-term as well as on a long-term base?
Thank you for this question. Difficult to answer. Well, in my personal opinion, we have no short-term solution for COVID-19 and for long COVID, since we have no magic pill to heal the disease. And the long-term solution, in my personal opinion, is a holistic approach with regard to the bio, psycho, and social impairments the patients have got. And with regard to your question, the major health problem with regard to social medicine, there is, in my opinion, no major health problem. The patients suffer from a wide variety of different symptoms. So in my opinion, there is no major health problem. To give you one example, when we perform a rehabilitation, at the end of the rehab, we have to do a social evaluation with regard to the work performance, work prognosis, for example. And there are, of course, long COVID and post-COVID patients with a negative work prognosis for the next 3 and the next 6 months. That is true. And the reasons are very different. Just to give you one example, the work prognosis can be negative due to shortness of breath after pulmonary embolism, or shortness of breath and exercise intolerance after acute lung failure, or the work prognosis can also be negative because of neurocognitive impairment with poor concentration and poor memory. So you see that there are very different reasons and very different implications the disease has on the lives of the patient.
Thank you very much. Speaking of social medicine, while being challenged on a global level by COVID-19, countries were affected differently. In their achievements to face the pandemic in the scientific and medical field, a lot of different aspects and results about COVID-19 and long COVID were gathered. Being now in this international symposium, which potential is still left to explore when thinking about international cooperation? And which steps do you like to see in the future?
Well, thanks again for this question. Well, first of all, I'm very happy that I can join this meeting. It's a very interesting meeting in my opinion, and we can learn a lot from each other. And I think it's important that we intensify such international collaboration. But in fact, we already have, if I'm allowed to mention it, a kind of collaboration with Professor Dong, who had the first speech today. Professor Dong, for instance, visited us 2 times in Flechtingen with 6 of his colleagues. I think it was 2015, 2016, and looked how we perform pulmonary rehabilitation. And he, of course, also visited acute clinics nearby. And in return, I was invited to his clinic twice, I think 2016 and 2018. And I could see Nafang University, where Professor Dong is working. I could see his lab, could have a day on the intensive care unit, and also talk to the colleagues. And what was also very interesting, I could take part in a very huge pneumologic congress that was really interesting. So in my opinion, such cooperations are very important, and I hope in future we can have this kind of cooperation again face to face.
Thank you, Pierre. One last question. There's some time left, short time. The intermittent hypoxia therapy, IHHT, you mentioned, is apparently made for improving lung function, but you also mentioned that there are some interdisciplinary effects of this therapy. Could you shortly comment on that, please?
Yeah, well, we implemented the IHHT therapy in April this year, and since then we treated around about 30 patients with this, for us, new therapeutic approach. And there is no study data, so I just can talk anecdotally about what the feedback of the patient we got. And the feedback, I can summary, is positive with regard to, interestingly, mood, and also with regard to exercise performance, not only with regard to the lung function.
Thank you, Dr. Schuler, for this fascinating insight into the 2 cases, as well as your interesting answers to our questions. Now it is my pleasure to introduce to you Dr. Galiazatos. He is currently the Assistant Professor in the Division of Pulmonary and Critical Care Medicine at Johns Hopkins School of Medicine. He is an expert in the diagnosis and treatment of obstructive lung disease, tobacco cessation, and the care of critically ill patients in the medical ICU. Besides that, he is in the position of co-chair for the Office of Diversity, Inclusion, and Health Equity at the Johns Hopkins Health System. In 2013, he co-founded Medicine for the Greater Good, a nonprofit organization that helps raise awareness of socioeconomic determinants of health and health equity in health professionals. Dr. Galiazatos is interested in understanding how socioeconomic variables impact healthcare outcomes and results in health disparities. Further, he researches effective strategies towards smoking cessation. He has studied population health and health equity strategies to implement community-level initiatives to help overcome health disparities. His expertise in dealing with obstructive lung disease proved valuable when COVID-19 evolved. He's going to give us insight into current findings in post-COVID-19 survivors. Thank you very much, and I give the word to you now, Dr. Galiatsatos.
Thank you so much. Let me go ahead and share my screen. So what we're going to discuss today is more of a focus of the pulmonary complications for patients who have survived COVID-19. And this is important to recognize as it may still be part of the phenotypes that we're seeing with long haulers and post-COVID-19 syndrome. With that said, though, I do want to make sure that we can focus specifically on what happens to the lungs, because to some extent, this isn't a new novel from SARS-CoV-2 and the disease of COVID-19, but rather falls along the lines of other biological features of severe critical illnesses, especially when there is an aberrant immune response. And that's what I want to focus on, because a lot of our strategies for survivors is a strategy focused on just that. So with that said, let's dive in. I don't have any disclosures to share. Our objectives today are to understand the consequences of critical illnesses. You'll see how we extrapolate there, to review current findings in post-COVID-19, and specifically just focus on the pulmonary complications. One of the reasons that here in our own post-COVID-19 clinic at Johns Hopkins, we see a great deal of patients coming into our clinic. So the first thing, I'm gonna take a step back, and you'll see the direction we're gonna go in, because in order to understand how we got here, history can teach us, well, are there other paths that have a similar roads traveled? And one of the things I always like to get to is sepsis. Recognize that sepsis in of itself is an aberrant immune response to an infection. So that means we have decades of sepsis-related outcomes in research in order to kind of give us a bit of guidance in a disease and phenotypes that we've never studied before. And I take a lot of comfort in that, because a lot of the interventions that we do in our own post-COVID-19 clinic for pulmonary complications really are extrapolated out of here. So sepsis, first of all, great deal of cohort of survivors, right? We saw hospital mortality rates here in the United States significantly decline. So that means there's a lot of survivors post-sepsis who are walking around with post-sepsis complications. And this is a great understanding, because nearly half of the survivors will continue having ongoing sequelae. Such clinical significant sequelae, that 1/6 continue having significant physical impairments. And interestingly enough, something that we're evaluating here is 1/3 of them still have a high risk for mortality up to about a year after their initial survival. So I'm hoping this begins to plant the seeds that the aberrant immune response you see in the initial stages of something like sepsis doesn't resolve just because they survived, right? It still seems to linger. That creates a lot of sepsis survivors to have ongoing symptoms. This is where we make the emphasis. These patients, surviving was really just chapter 1 for them. They haven't regained their quality of life, and they continue having significant physical limitations that are oftentimes derived from somatic complications such as pulmonary and so forth. And again, we're going to extrapolate here because we need a compass. We need a North Star to follow for post-COVID-19 symptoms. SARS-CoV-2 is still a virus, and it's still going to obey by biological laws. And so we need to see if there's other phenotypes or syndromes such as sepsis that we can extrapolate from. So surviving sepsis, I was hinting at this, you already have significant physical limitations that may come from a good portion of them from a pulmonary standpoint. And then there's other impairments, cognitive, mental health, recurrent infections, and even exacerbation of chronic medical conditions. The last part's an important one, because for post-COVID-19 complications to the lungs, that's where we actually evaluate. Is this a novel disease state that is occurring? Or does it seem to take from their underlying lung diseases that just get worse anytime there is an infectious pulmonary complication? Now, COVID-19, you're saying to yourself, okay, he's bringing up sepsis, right? A pathological syndrome that we've studied, the name being coined since ancient Greek times, studied extensively here in the United States since 1979 with hospital coding. So again, we're using sepsis as a potential syndrome to draw from. So how does COVID-19 also relate? Well, But both of them, at their heart, the SARS-CoV-2 causing COVID-19, and in the moderate to severe cases of a COVID-19, it does seem to be more endothelial dysfunction, right? That's an important thing to understand at its basis, biological root, because sepsis is the same way, right? There's an endothelial dysfunction that begins to happen, a lot of it because of the aberrant immune response. So how aberrant is this immune response? Meaning how much of a deviation does the immune response happen in COVID-19? And one of the things that I really appreciate about this study coming out of Northern Ireland is the inflammatory response of COVID-19. We're going to go over certain cytokine profiles. So first of all, what they did in this study was that they took patients, HCs, healthy control. COVID stable means you had COVID, mild cases, nothing else. COVID ICU meant that patient went into the intensive care unit to get intensive care unit resources. Does not imply mechanical ventilation, could just imply some high flow nasal cannula and so forth. And they compared this all towards a common critical disease that lands patients many times in the intensive care units, and that's a community-acquired pneumonia resulting in intensive care unit admission. Now, the CAP ICU patients all did receive mechanical ventilation, so the most severe phenotype of a critical illness. Now, I'll say this because what COVID ICU patients, which is, I would say you can use that synonymously with severe COVID, they seem to have an immunological profile that's similar to severe community-acquired pneumonia. Both of them have elevated pro-inflammatory markers right off the bat, interleukin-1 beta. However, there is a statistical significance, as you can see, between IL-1 beta coming from COVID and IL-1 beta coming from CAP, both of them in their severe states. Interleukin-6 also elevated, and again, you can even see a statistical significance where it's much more amplified in patients with severe COVID-19 ending up in the intensive care unit. Compare this to interleukin-8, another pro-inflammatory marker. Both of them well elevated, not a statistical significant difference. TNF-alpha, another, again, pro-inflammatory protein, also significantly elevated in both COVID and CAP, with a statistical difference between them, much higher, much more amplified in our patients with severe COVID-19. And this is actually one of the things that I find fascinating with regards to this immunological profile, is that the anti-inflammatory markers, kind of the yin to the yang, in order to maintain some level of equilibrium with an immune response. We want the immune system activated to kill off the infections, but we don't want it so activated that results in sepsis, right? That it results in that aberrant immune response. However, we do recognize that that syndrome of sepsis occurs, and severe COVID-19 occurring as well seems to have similar issues with anti-inflammatory markers. However, in this study specifically, they saw it elevated in patients with severe community-acquired pneumonia resulting in mechanical ventilation. Now, that anti-inflammatory marker elevation, that's important, right? Because having that anti-inflammatory marker helps to attenuate some of the pro-inflammation seen from the earlier markers, in addition to helping with healing, right? So when you see that in patients who survive, the lungs, for instance, one of the organs, can begin to heal overall. In COVID-19 severe cases, actually you saw a blunting of IL-10 response, meaning you had a massive pro-inflammatory response that you can say, while there's some statistical significant differences between that and CAP ICU, clinically it's probably just in the same ballpark, regardless of the statistical significances or not. But the lack of an abundant anti-inflammatory response, that doesn't sit well with me. And I think that biological role right there is one of the reasons we see so much post-COVID-19 pulmonary complications. Now, so again, from a COVID-19 standpoint, the immunometabolic profile, you see a significant rise in pro-inflammatory markers. All of them are going to result in significant endothelial dysfunction. That endothelial dysfunction will result in pulmonary edema in the lungs, to alveolar damage, to diffuse alveolar damage, which is analogous to acute respiratory syndrome, acute respiratory distress syndrome, ARDS. So you're seeing this, and the one thing I want to say is you see this as well in sepsis. So I'm putting this together because back around April of 2020, we launched our first ever post-COVID-19 clinic. Well aware, just as many of my colleagues listening today, we haven't read about it in medical school, we haven't read about it in a textbook. COVID-19 is new, post-COVID-19 is even newer. So we need to be prepared. And from our standpoint, seeing the data coming out about the immunometabolic profiles of COVID-19 and seeing that that Venn diagram overlaps with pathological stages such as sepsis, actually, we didn't need to look that far because we had kind of a post-sepsis clinic at Johns Hopkins and said, all right, well, let's turn that on its heels and just call it a post-COVID-19. And to some extent, we can be prepared for what we're going to see in regards to certain outcomes of patients. So post-COVID-19, again, we're going to have that focus of pulmonary, but I really want to make an emphasis that massive aberrant immune response, and you'll see why I keep saying those terms in one of our slides, that kind of validates when autopsies, you see a lot more inflammatory markers than you see really any viral or viral presence. But because of that cascade of inflammation from head to toe, every organ is relatively susceptible to that endothelial dysfunction that will result in organ dysfunction. So from brain being an organ, we see chronic issues from mental health to cognitive impairments. From cardiac issues, we still see ongoing things such as myocarditis, or sometimes actually a kind of a deviation of appropriate rhythms. A lot of patients suffer these tachyarrhythmias, sometimes known as POTS, other times it's hard to classify overall. You see blood clotting occurring, you see renal dysfunction still occurring, and things as, from quantity of life impairing organ dysfunction to quality of life, such as hair loss. And we see that it's actually in our clinic, astonishingly, a lot more in the female population. But let's focus on the lungs, because this is the lungs are often the impact of a lot of infections, right? The lungs are one of the few organs that have a direct connection, not only to the environment, but to a high abundant microbiome, which is the oropharynx. So they're going to be constantly impacted by a variety of pathogens, and they have to constantly fight in that term to kind of keep things at bay. And the immune system response is important because it tends to dictate to some extent how well the healing process will occur. And that's always important to recognize, because a lot of these symptoms, as you'll see, sometimes they're really just part of healing as the patients kind of recondition themselves. So we get our post-COVID-19 clinic, we're up and running. And so what we have to try to figure out is, are patients having pulmonary complications that are specific to the virus-specific pathophysiological changes? Or are they more of an issue of the immunological aberrations and inflammation in response to the acute infection? Number two is actually things that we see in post-sepsis survivors. And this is, again, important to recognize because we want to be able to say, can we extrapolate from our post-sepsis cohort and use it in post-COVID-19 patients with ongoing pulmonary complications? The third objective, or the third thing that we look for, this is important because patients who get into the intensive care unit, actually their complications may not be at all related to the virus or at all related to the aberrant immune response. It may just be related to the life-saving interventions that they received. This is incredibly important to recognize because being put in a medically induced coma results in significant muscle wasting that can have significant physical limitations as patients survive. And there's a different kind of therapeutic interventions that we need for that. Delirium tends to happen extensively after ICU admission. So we need to be cognitive overall of how to manage these patients and where do we think the precipitating factor is. One of the things that I liked out of one of the first post-COVID-19 studies coming out of Jinyindan Hospital in Wuhan, China, one of the first hospitals, if not the first hospital, to care exclusively for COVID-19, said they followed patients post-COVID-19 in order to see what they're still experiencing. Now, this group used its own severity scale, on a scale of 1 to 7. Obviously, those who passed away, having the number 7, were not followed for these reasons. But I'm not going to go through the study extensively because I want to leave time to kind of focus on what they found related to the lungs. Lots of symptoms. And again, these slides should be available so you can go through them more thoroughly if you like. But this is the part that I thought was fascinating. So there seems to be a diffusion impairment still in patients with more severe illness, right? So scale 5 to 6, remember the disease severity, they did 1 through 7, 7 is death, but 5 and 6 are rather sick individuals. So if the disease in of itself, COVID-19, was more of the severe form, right? And as we made a mention earlier, severe forms of COVID-19 appear to have that amplified immune response out of proportion to what the virus is actually doing. And that led to active diffusion impairment, which again, the patient's meaning they'll get out of the hospital still needing oxygen. And when they come to our clinic for this management, our job is to evaluate, is this healing that will ultimately self-resolve and their oxygen needs will kind of disseminate over time? Or are they having an aberrant immunological response to healing that will result in permanent fibrosis that we need to act on sooner than later? So this is where the plot really thickens for us, because in sepsis survivors, we had a good portion of patients who were very similar. They left the ICU, their sepsis, regardless if it was a pulmonary etiology or non-pulmonary related that led to sepsis-related ARDS. We began to fight that in certain ways for those who came to our clinic still needing oxygen and with some imaging to kind of relay to us, we need to intervene. What that intervention is, we'll discuss it in a second. So from the pulmonary complications, this is important to recognize, right? These are what our patients are going to come in with. They're going to come in with shortness of breath still, decreased exercise capacity, and maybe some hypoxemia as well, still needing some supplemental oxygen. And the objective findings, yes, if we get lung function tests, well, then we can see diffusion capacity reduce, the DLCO. We can still see restrictive pulmonary physiology. And again, with imaging, you can see some other objective findings, such as ground glass opacities. And in a few patients, we definitely see the fibrotic changes. So this is the part that is still one of the hardest things to kind of know and where to follow this algorithm, but I can give you a little bit of peace of mind of how we think we do this. Much of it extrapolating from our post-sepsis survivors, and now with a little over 200 post-COVID-19 survivors with pulmonary complications, we feel a little bit more certain of what we're doing. So the first things first is we're trying to understand, is this potentially part of healing? The analogy I always give here, if your bone broke and I took the cast off months later, you're not up and running around. You're going to experience significant pain, cramping, and so forth. And that's just because the body's trying to heal, trying to regrow the muscle that it once lost through just, stasis of the leg. And the same complications can happen here. Patients become significantly deconditioned with severe illnesses of the lungs. They're not using their lungs. There's a loss of function there that's expedited because of that pro-amplified aberrant immune response. So when we see patients, especially within the first 4 weeks of hospital discharge, that's what we're trying to say. If they're healing, we don't want them to deviate from that. So we monitor that closely. If we think there's an aberrant healing process, then we try to deviate from that and bring them back to more of an equilibrium state. So this is the side note I was going to say. This is not what we have done, but this is so fascinating because what we said earlier, right, in regards to that aberrant immune response, little virus found in autopsies of those who died, but tons of inflammatory markers, leading us to believe severe COVID-19 is more of that aberrant immune response. Same thing that we see when we've taken biopsies of patients' lungs as they're healing, that they seem to have an accelerated form of fibrotic changes that we feel that's a deviation from normal healing and we need to interfere on. So the management of this. So one of the algorithms that I want to emphasize here is when we evaluate the COVID-19 survivors within the first month, definitely within the first 3 months of being discharged from the hospital, the first question we want to gain, and sometimes the patients don't know how to relay this to us, so we have to do a lot of chart digging, but how bad was their COVID-19? How severe was it? Was it moderate to severe, meaning resulting in need for supplemental oxygen to helping with work or breathing, to needing even mechanical ventilation with or without ECMO? And then we follow algorithms. Honestly, what we have done now, really sharpening kind of how we evaluate these patients other than a detailed clinical history, we really just do that in addition to clinical imaging, a dry CT scan within the first 12 weeks. And we compare that CT scan to some extent with how the patients looked prior to that. Now, with that said, that's important to recognize in order to see how we move forward with the patients. We may consider lung function tests, 6-minute walks, and sputum samples. These are just based on clinical judgment. And again, after 12 weeks, the patients are continuing to have symptoms, we reevaluate. Now, one of the cases that I'm going to bring up briefly was a 59-year-old who came to us, rather sick, intubated for 3 weeks, 2-month hospitalization, discharged on oxygen. He only had myasthenia gravis that honestly was well controlled. And so this is his lungs in May 2021. This is his lungs in June of 2001. A great improvement in the ground glass opacifications. And to some extent, I know I can't show you the whole thing. I apologize. There were some fibrotic changes early on that we were seeing. Kind of fits actually a non-specific interstitial pneumonia pattern, NSIP. So what did we do here? And even the lung function test showed more of a restrictive physiology. As you can see, the TLC greatly reduced at 68%. DLCO was actually okay. What we actually did was we gave him steroids. And this came at a time where some of our colleagues put out a study strongly emphasizing this. We used to do this all the time for post-sepsis survivors who have pulmonary complications. And so steroids is one of our main go-tos if we think there's an aberrant healing process to help patients. So long story short, we'll wrap up with this. Managing patients with post-COVID-19 pulmonary complications really needs a detailed history of the severity of their COVID-19, their hospitalization, and what symptoms are going through now, and you supplement it with objective data such as CAT scans, specifically in the first 12 weeks. If they have ongoing symptoms, then clinically, I would suggest PFTs and so forth. So we'll stop here and take any questions that you may have. Sorry for lackluster ending, but yeah, let's stop here. Perfect. I'll stop sharing my screen as well.
Evkaristo, and thank you for your presentation.
Oh, parakalo.
In your presentation, you seem to avoid the term long COVID, but you present impressive data on the long-term consequences of COVID-19 disease. You seem to prefer the term ongoing COVID, long-term COVID, or chronic COVID. Do you see different pathophysiologic concepts and understanding behind these terms?
I do, and it's a great point to emphasize, just because from my standpoint, I think these are post-COVID-19 complications. The challenge is, I think the phenotype specifically around post-COVID-19 warrants kind of its own definition. And I say this because, you know, there's good studies that showcase certain aberrant immune responses afterwards that discuss autoantibodies that get created in post-COVID-19. I don't think that's what's happening in the lungs, and that's why I avoid it to some extent. I'm happy for post-COVID-19 complications of the lungs to be grouped under the phenotype, but I think, you know, with that conversation, it may deviate from what's happening to the lungs that's not actually unique to COVID-19. We see this with parainfluenza. We see this with certain bacterial infections. We see these same complications with those. That's why I was saying earlier, our post-sepsis patients in our post-sepsis clinic who had these kind of pathologies, you know, we treated them with steroids, and for the majority of them, we were able to get them back. So my hesitation of calling pulmonary complications under that umbrella of a syndrome of post-COVID, my concern of that, I think it shies away from recognizing this can happen. This tends to happen more often than we like to emphasize before the pandemic. And being a lung doctor at Hopkins, maybe I'm just biased with people who I see. So from my standpoint, I'm happy to call them post-COVID-19 complications. I don't have any objection with having it fall under that syndrome, that phenotype, but I don't want that to shy away from recognizing that this can happen to the lungs, especially with a bad infection, especially when that results in such an aberrant immune response. And I really want to be mindful of that because it really needs certain interventions.
Thank you very much, Dr. Galeazzatos. A lot of long COVID patients were never in need of hospitalization, let alone ICU treatment during acute COVID, but still developed severe symptoms afterwards. Are there any results in cytokine profiles in those cases, which we would call long COVID patients, that prove similar to the one we've seen in COVID, post-COVID, or post-sepsis patients?
No, and that's a great point to bring up. And obviously this has already, as you can see, some potential implicit bias, because it's easier to study patients when they're in their hospital. It's easier to draw blood from them and make these characterizations. And so you're right. We talked about extrapolating from sepsis to severe COVID. We extrapolate even with severe COVID to those with more mild cases who were never hospitalized, who have such symptoms. And we actually do see that. And it's fascinating. It tends to happen in younger generations, 20 to 30-year-old, especially men. And that I apologize, I misspoke, women, especially women. So women who tend to have more of a milder case seem to have more pulmonary complications with objective findings, meaning they were never hospitalized, they were never put on oxygen, but yet when we run their CT scan weeks after their final symptoms, even maybe sometimes they had a good PCP, primary care physician who took an x-ray, looked good. 12 weeks later, they're developing fibrotic changes. So those are patients we do see. At this moment, as of October 12, 2021, I'm not aware of immunological profiling of patients in the outpatient world for that purpose and tying it into post-pulmonary complications. If that comes out, great, and I'll be one of the first to read it. This is one of the reasons I wanted to extrapolate, because I think what's happened to these patients in our clinic, again, 20 to 30-year-old women, a lot of it probably has to do with the inability to heal, so or to heal appropriately. So We do see that, not as frequently as the hospitalized patients, but we do see it, and it's an interesting consequence that we're investigating more. The one thing I do want to make a point of, real quickly, all these patients, in case you're wondering, were not vaccinated to begin with and developed. What we haven't seen in our clinic are vaccinated, got a breakthrough case, and now we're seeing us in post-COVID-19. And like I said, we have close to a little over 300, 200, 2/3 of them are predominantly pulmonary. So it's interesting to see what would, if we get some patients who develop COVID after vaccine. I say this because I think one of the benefits of the vaccine could be mitigating an aberrant immune response.
Thank you very much. Another focus in your research is health equity. With your organization, Medicine for the Greater Good, you promote active community engagement. Have you had experiences with actionable recommendations to communities in the region surrounding you in order to deal with long COVID?
100%. And I truly appreciate you emphasizing that. I want to all your listeners, I want to make a point to recognize that as physicians, as healthcare professionals, we practice medicine. Even though we're seen as health providers, we practice medicine. That's what we do, and we react to diseases in real time. And medicine and health is not synonymous. And for a lot of our post-COVID-19 patients, a lot of them were patients to begin with, and now they are, and it is a struggle. So our community engagement efforts are out there in order to kind of break down any stigma about post-COVID-19 patients and the symptoms they're experiencing. And I say this because these symptoms are so non-specific. Like saying I'm fatigued, people are like, I feel fatigued, but this is like a life-changing fatigue where some of our patients have lost relationships and jobs. The economic impact has been massive. So a lot of our community engagement efforts is going around talking with faith-based organizations to school systems and their networks to discuss what you can expect from patients who have survived COVID, regardless of hospitalization. Because like we said earlier, you will still see the post-COVID-19 complications happening. Getting them involved into an understanding and hopefully creating a peer-to-peer network where if you do, someone from their congregation or school system develops post-COVID-19, when I said medicine and health are not synonymous, we're hoping the community can fill in that gap and really help with allocation of resources and implementation of just support systems to help their active human being, their active neighbor, their family member, in a time where, for a lot of these post-COVID patients, post-COVID-19 was nothing compared to the symptoms they're experiencing now. So you're spot on. We do a lot of community engagement in order to help with that and mitigate those issues.
Thank you. Thank you very much.
Thank you very much again, Dr. Galiatsatos, and for everybody from the audience for the questions being submitted and for the discussion. Now we will conclude this meeting with a panel discussion where the speakers have the opportunity to share their visions and their expertise on common problems in long COVID management. At this point, I especially want to welcome the Head of Research and Innovation of the Media Group, Dr. Laura Golania. Dr. Golania is, you could say, the coordinating force behind our COVID and long COVID activities, and also our public health and health economics expert. Laura, we are thankful that you could find the time to attend this meeting and contribute from your specific point of view. So let us go ahead with a panel discussion. Dear panel discussions, is everybody on stage? Ah, yes, fine, thank you. Dear panel discussants, you have presented fascinating results and possibilities to deal with long COVID or COVID. Please answer in one sentence, what is long COVID to you?
Dr. Stan Windsor, I would like to give you the word first.
So long COVID to me, I think, doesn't need one sentence, just a couple of words, the new normal.
Thank you very much. Dr. Pierre Schuler.
Well, in one sentence, long COVID is, in my opinion, a life-changing multi-organ disorder for some patients, and for us, it's a challenge.
Thank you very much. Dr. Galiatsatos.
I love the two comments. I will keep mine brief. I'm hoping long COVID, while it may become the new normal, becomes a catalyst we need to see a lot of health change with multidisciplinary clinics and so forth. I'm hoping there's a silver lining to what our patients are experiencing.
Thank you so much. Dr. Wright, your word.
Yeah, I would summarize long COVID or COVID as a structural and societal change, or in a nutshell, revolution of health systems.
Thank you so much. Chris Altman.
What is each of yours vision to make the achievements you presented here available for everybody with symptoms after COVID and with long COVID in need? Where will we stand with COVID and long COVID therapy in 3 to 5 years?
Dr. Peter Wright, I would like to ask you first to answer that question.
Yeah, obviously we'll look at it from a rehabilitation and exercises medicine perspective. And I would see that there should be a lot of international exchange. It's a global challenge that we're facing, and we've for too long lived in isolation. And I think the knowledge exchange and also kind of structural revolution, that's what I want to see in rehabilitation, using all the armory that we've got. Yeah.
Thank you. Dr. Schuler.
Well, I would also try to answer it in one sentence. My vision is best long COVID treatment to all who need it, everywhere and for free, of course. And in 5 years, I think long COVID will not be the main health issue like it is now, and also COVID-19. I hope it will return possibly in something like the flu, a seasonal topic, and possibly, nobody knows, of course, we will be vaccinated once a year. We will see.
Thank you so much. Dr. Windsor.
Yeah, I think just following on from what the last couple of speakers have said, everyone's always speaking about comorbidities and recognizing the comorbidities and the prevalence of long COVID because of comorbidities. And so my vision and hope for the future, the next 5 years, would be a higher prioritization put on general well-being and general health. Obviously, from my perspective, made possible through digital means, giving people in socioeconomic disparity the ability to access the rehabilitation that they should have through digital on-demand means.
Thank you so much. Dr. Galiatsatos.
I'm hoping a new spotlight happens in the field of medicine. Dr. Wright began to emphasize it and did it well, where so much of our bias comes into surviving. I mean, even sepsis, the campaign was called Surviving Sepsis, without this notion that the survivors are patients in of themselves. I mean, they're debilitated, greatly impacted. And I'm hoping where post-COVID is in 5 years, even if it's not called that, I'm hoping, like I said earlier, it becomes a catalyst to creating a new multidisciplinary team to helping survivors get back their quality of life. And that's going to demand from physical therapists to psychologists to internal medicine physicians and so forth. It's going to take a revolution in medicine. And while we have great breakthroughs, we have great minds. If that can come of this, I mean, all these patients and their troubles will not been lost for naught.
Thank you so much. We have now a question for Dr. Golania. Chris, please.
Please, if you don't mind, there's one interesting question that came up. I would put to the panel before that. There is intensive research to clarify the pathophysiological origin of persisting COVID symptoms. What do you think will be the result of this research? Will long COVID turn out as 1, thrombotic microvascular disease, or 2, autoimmunological disease, or 3, a neurological disease, or 4, psychosomatic disease, or 5, only a buzzword from our era? Oh, please don't answer all of the above. Please try to be specific. So,
okay, I see the biggest smile on Dr. Wright's face, so please go ahead.
No, I mean, I was just smiling because obviously we could say all of the above, I think this needs to be a joint effort of the whole panel to answer. My personal view is it'll be still one condition with multiple facets, and depending on the journey of the patient and existing comorbidities, etc., it might go one way or the other. I can't see it being separated into different others, but you know, there are probably more qualified speakers in the panel than me.
Okay, Dr. Galiatsatos, please.
Yeah, no, and Dr. Altman, you gave us a hesitation saying not all the above. I think it may, but depending on how we're coming at it, you know, from our disease studies for pulmonary complications, honestly, post-COVID-19 and those fibrotic changes, other viruses do just that, right? I think what we're going to discover is that a lot of attention needs to be shifted from basic science labs to more clinical research of how healing happens, right? Just because we can cure something doesn't mean the patient comes out of it unfazed. You know, in medicine, I think the dirty secret that we don't share what doesn't kill you. It's not that it makes you stronger, it makes you incredibly weak. And other than great physical medicine and rehabilitation physicians and physical therapists and occupational therapists, we don't have a lot of interventions, even though we've known this has existed. So I'm hoping, you know, we do begin to put more emphasis on that healing process. And I do think all those lists that you gave us, you know, certain diseases are going to fall in that state. And all of that does warrant attention, because even the psychosomatization conversation, I mean, that to me, you know, mental health up through all of them should also be emphasized. Surviving a bad disease carries complications for many people for years to come. And I love this conversation because I'm hoping it spots like that with such an emphasis, because our health system really needs to focus on them too.
Yeah, thank you so much. Dr. Schuler, your thoughts on the matter?
Yeah, I think everything important has already been mentioned, so I would make a short answer. For me, it's all 1, 2, and 3, and it's far out of my experience to answer these questions because it's a multifactorial genesis, in my opinion.
Thank you so much. Dr. Windsor, you nodded in agreement.
Yeah, I like Dr. Wright, there are people much more qualified to talk about this than me, but I think what this does highlight is the buzzword for this panel, which is interdisciplinary. So I think the interdisciplinary nature that needs to stem from long COVID is highlighted by exactly this.
Yeah, thank you so much.
Let me just comment. So nobody of us is expecting within the next 2 or 3 years that an antibody comes up, which has to be determined, and if it's elevated, we know what it is. So that was the background of my question. Okay, how do you deal with...
Excuse me, there would be a question for Dr. Golania.
Oh, okay. Dr. Golania, yes, excuse me. You are a public health expert and an expert in national and international health systems. You know the numbers and you've heard the expert statements. Please give us your opinion. How will health system react for the challenge of COVID and long COVID? And will long COVID create a new paradigm of treatment pathways or reimbursement structures?
Thank you. As we have heard a lot of times already, a multidisciplinary treatment approach is necessary, given the diverse and varying symptoms. However, I think that a truly interdisciplinary approach is currently uncommon. So many healthcare systems do not adequately support such a clinical picture, especially regarding patients' referrals and reimbursements. And with long COVID, we are dealing with a problem that is occurring on a massive scale, and that is having an impact on society and the sustainability of the health systems in general. So in my view, we should therefore form an alliance, as a lot of people already said before, and this alliance should involve all medical disciplines and all stakeholders, including governments, payers, healthcare providers, and the scientific community, so that we find a way to treat long COVID fastly and unbureaucratically. So, and with this alliance, then we could pass on the knowledge, for example, gathered today, and know the right, and to the important parties, pick it on and pass it on. So I see the symposium as the first important step towards forming such an alliance, as we have exchanged great ideas and enter into this interdisciplinary dialogue. And in order to answer your questions, I see it as an obligation to create a new paradigm, and especially concerning patients' referral, treatment pathways, and reimbursing structures in order to effectively fight against long COVID. So in my opinion, the question is therefore not if, but how long will it take to do that?
Do we have comments on that from other panel discussants?
I like what Dr. Golania emphasized. I agree. I don't think it's an if, I think it is a when. You know, there's so many things that COVID-19 has called to action with great moments of time where we saw trying to help with healthcare disparities with certain populations disproportionately impacted by others. There's been an ethical reckoning to make sure we can try to mitigate those. What I'm hoping is, though, that these moments of action do transition into a movement. So I agree with Dr. Golania. I think it is a matter of when. We just can't forget this. I know we all have, not us maybe in the panel, but a short-term memory, and we're so excited to go back to how things were. But we realize how things were didn't really help us to stop the pandemic, and especially it's not doing the best to help out the patients with post-COVID-19. So I really do think we can evolve as a medical system after this. And you know, having these kind of panel conversations, I think hopefully continue acting as catalysts to do just that.
If there are no other questions, I would just comment on that as well. So I think in every crisis lies an opportunity, and that's how we need to look at it. We are in this together, and because it's a global challenge, I think it's about time that we have you know, this knowledge exchange, using it as an opportunity, restructuring, or in a military sense, we would say regrouping ourselves and wider society. Because the one thing is for sure, it has brought to light any shortfalls of society, of governments, healthcare systems, etc. So in the times of crisis, I think we need to look forward and especially stand shoulder to shoulder and make this almost revolution happen, and have this democratic approach to medicine, to healthcare, and of course in my area, rehabilitation.
Yeah, to me it seems as if the COVID pandemic has diagnosed the weak points of our health systems all over the world.
Mm-hmm. Yeah, I'd also just add to that I think that, like it's already been said, if we have a tendency as a society to forget about these things as time goes on, and I hope that that each individual country's and national economic recovery doesn't outshine the need for change and transformation within the healthcare systems, and that it's recognized that change and transformation and innovation within the healthcare system is actually part and parcel of our health and our national health and national economic recoveries. The more people that can get back to work quicker, the more people that can get into work at all, is part and parcel of both our healthcare systems, our rehabilitation systems, and our economic recovery as a global community.
Nice final comment for the panel discussion, Laura. What's that?
Not at all. We have questions left.
Okay.
There's one question. How do you deal with long COVID patients that had a very mild or asymptomatic acute COVID infection and are now suffering from long COVID symptoms, but are denying the existence of COVID altogether?
I'm going to take a first crack at that.
Yes, please.
And I say this because, you know, that kind of culmination, I think, is hopefully results in, I'm going to answer it in two ways, and I'm going to try to be brief because I know my colleagues may have input. But I feel like those kind of outcomes is kind of a failure of the medical fields. Much of us in medicine, and I'm guilty of it as well, we practice kind of in our own secluded manner away from the community, and we engage with them if there's a public health crisis. Meaning if people aren't believing in COVID, I do think it's a fault of medicine that we haven't been present in the community. We haven't embraced that we're not physicians and scientists. We're community members. We're brothers, sisters, husbands, wives who happen to be those things. And if a community doesn't believe in COVID, that's been a failure on our end to reaffirm ourselves, not only as a public trust, but a community member. So I'm hoping another change makes a hospital and health systems realize we got to engage with the community constantly, right? We can't just appear when there's crises and expect them to suddenly be won over. So I always see that as a surrogate to say we failed them. And at the same time, honestly, it's not I don't have a quick fix when they say this, but I do have conversations that we try to, essentially it's just being human to human. I try to regain their sense of trust, because those kind of patients we've seen, and the majority of them, especially if they still follow us in clinic, they do come to terms and believe in it. Whether they believe it in like a religious awakening or finally accept the science. But again, that takes time. We need to do better. We need active engagement with the community so that doesn't ever happen again. I mean, the disbelief in science from my standpoint, I mean, should shock us all to say we need to do more.
I would probably add to this. I personally haven't come across a single patient with long COVID who was in denial, but that doesn't mean that they're not out there. We in the UK have a link between some of these groups and ethnic groups as well. So there is a cultural component, for instance, with the Asian community. Now that is cultural, religious, whatever, believe in fake news. However, in my opinion, that's probably the limit of authority of government, of the medical entity, and it needs ambassadors of those communities. So you need to have an ambassador for, the truth and for science and for the facts, who is part of their family, their community, etc. And that is probably the only way to get this denial resolved.
Thank you so much. Another question from the chat is, which clinical parameter is a sign for good prognosis for patients with long COVID complications? Dr. Pierre Schuler, I would like you to answer this question.
A clinical parameter for a good prognosis for the long COVID disease, it's very difficult to answer. In my opinion, there is no special clinical marker, since we have also no marker for diagnosis of the disease long COVID. So I can't answer this question. There's no specific marker, in my opinion.
Yeah, is there any answer to this question, Unsaid?
I agree with Dr. Schuler. I just want to make a point, if you become very centric with an organ like lungs or heart, you can do testing that, we extrapolate from, but, those are markers of injury or healing. It doesn't necessarily confirm it's post-COVID. So I agree. And I see this because I always make that point to my patients, like, this doesn't confirm post-COVID complications, just confirms an injury. And we have to sleuth through what's the etiology of that.
Yeah, thank you so much. It all goes into the same direction of treating the whole human, not only the patient in one specific field of medicine. Dr. Golania.
Maybe to give another point to this question, in that moment when we're actually treating a long COVID patient, we already made a big step, because there's so many patients not knowing what they're suffering from, and nobody actually knows how to help them. So when we started the treatment, I think then we already have a marker where we can say, yeah, now it's going in the right direction and we can help. And so that is, I think, an important aspect to consider. Knowing what it is and knowing that you can get treatment and it will get better.
Thank you so much. With an eye on the time, one short question from the chat. Do you have patients with long COVID symptoms caused by vaccination? This would go more into the direction of Dr. Galiatsatos or Dr. Pierre Schuler.
Yeah, I mean, I haven't seen any patients with prolonged vaccine complications in our clinic. And the other emphasis, as said during the presentation, is I haven't seen anyone who vaccinated first COVID in that timeline and then came to our clinic. So, so I haven't seen the post-vaccine complications in addition to that other timeline that I'd like to emphasize.
So that would be an interesting field of research to see if long COVID is also, or if the vaccination also prevents long COVID.
And there's a Lancet study out of the UK actually that suggests that. It wasn't the intention of the study, but it does seem to suggest a mitigation or lack of symptoms if there were breakthrough cases.
Yeah, I can confirm this. I would say, having worked with long COVID interest groups, etc., patient groups, I'm not aware of a single case where a vaccination had triggered long COVID symptoms. Indeed, there is some data suggesting that it has more of a preventive effect.
Thank you so much. With that being said, we are at the end of our time frame for the panel discussion and at the end of our meeting. Thank you so much for being here. Chris, the word is yours.
So now we're coming to the end of this meeting. Thanks to all of you for attending, for asking, for sharing your opinion, and for your commitment to this field. We hope you found this conference helpful, that you could accept the digital format we chose, and that you didn't have any technical issues. We are sure that all of us have learned a lot today.
What are the preliminary results we can conclude from this meeting today? Let us try to give you some take-home messages. First, there is no alternative to a multidisciplinary approach when dealing with long COVID. We should not be tempted to claim COVID or long COVID for our specialty. Long COVID is a multi-system disease.
Second, international cooperation must be established or widened. We need input from scientists and colleagues from outside our regional box.
Third, digital solutions are necessary not only for communication between medical professionals, but also between patients and professionals and between patients themselves. Only by gathering adequate multi-center data on a digital base, we will be able to be successful in fighting the consequences of long COVID.
Fourth, we need to address HMOs to speed up evaluating, certifying, and most of all, reimbursing the solutions we have developed. We need a framework of patient referral, accepted treatment pathways, and financing for long COVID management. This framework should respect the interdisciplinary nature of long COVID.
Fifth and finally, we all need patience and a long-term commitment to our common goal to improve life and health for people affected by long COVID. As we will collect your question and comments from the chat, we will learn more about specific aspects of interest from you. We hope that you could learn something today or that you are inspired to connect with other professionals to work together. In the follow-up we will post, you will find today's content as well as the Q&A section of today's chat with the answers to all the questions, including the still unanswered questions from today.
There is much to do to build up satisfactory structures to help people with long COVID. In our eyes, this meeting is an important step on the way.
We hope to continue this important conversation and exchange of expertise and know-how. If you are interested in as well, please let us know. There's a form to the right where you can send us your feedback.
So thank you, everybody. Please stay in contact.
Take care and have a good day in Baltimore, a good night in Guangzhou, and a good evening in the UK and Germany. Thank you for your participation and attendance. Goodbye.